Good afternoon, everybody. The first item on the agenda is the appointment of chair. This is just to note that I, Sarah Hill, was nominated as chair at the annual meeting on the 13th of May. So you stuck with me again. I'll just say who's here because we've got apologies from Mr. Durrani. Mr. Robinson is replacing Mr. MacDonald on the committee. So here's a full-time member. So Mr. MacDonald isn't here then, Ewan? Vaguely confused manner.
That's right, yes. So Mr. MacDonald is no longer the member of the committee. Mr. Robinson is permanent replacement.
Fine. Okay, that's no problem at all. And then Mr. Smith is substituting for Mr. North. And we welcome Sean McGill, Dr. Sean McGill, who's Assistant Director of Public Health, standing in for Mike today, who's on his holidays, and Paul Harrison here as the lead member. So with that, we'll carry on over the page to, well, my page anyway, election of Vice Chairman. So do we have any nominations for Vice Chair? Mrs. Knight. The seconder for that? Mr. Morris. Any other nominations?
Hi, Chair. I'd like to nominate Mr. Poland for the Vice Chair, please.
Seconder? Mr. King. Thank you. And in that case, we will hold a secret ballot. It is traditional on these matters. Just there's a man here with some bits of paper scribbling quickly.
Writing very quickly.
Talk amongst yourselves for a moment.
Okay, the result of the vote is 6 votes for Mr. Robinson and 3 votes for Mr. Poland, with 1 abstention. So Mr. Robinson is appointed Deputy Chair for the rest of this year.
Thank you. So we'll move on to the minute. I can't even speak now. The minutes of the meeting held on the 4th of March. I propose these are taken as read and signed. Does everybody agree? Thank you. With no questions from the public for item 4 and item 5, questions asked by members under the relevant standing order. Received 3 questions, one of those members being me, so I've got to ask myself a question. Anyway, members have been provided the written answers and the answers have been published on our website. Those members now have an opportunity to ask a supplementary question. Mr. Piper, would you like to ask a supplementary?
Yes, Chair, I would like to. My original question was about the training of doctors. The supplementary question would be, what about the training of midwives, and is that sufficient?
We'll have to come back to you with that, clearly, but we can't do so. Mr. King, would you like to ask a supplementary?
Not at this moment, but I'm very grateful for the information. Thank you.
Thank you. I'd like to ask myself a supplementary, because as you'll have seen, members will have had an email sent round, thanks to Mr. Poland, who had asked a similar question of UHL not long ago and had a slightly different answer. So I'd like to ask UHL why people are being told one thing about extensions to car parks and we're told something completely different. So we will get on to that. Thank you. Yeah, please, Ewan.
UHL are hot on the answer. They just said it wasn't intentional. So yeah, that's the answer I received from them.
Which one wasn't intentional?
Yeah, I'd still like to know publicly, are they going to build an extension to the car park? So thank you. Mr. Poland.
For context for members and for listening, following approaches from constituents regarding parking at the LRI in particular, I organised a meeting with the chief executive along with Mr. Smith and Mrs. Deborah Taylor. We had a chat through the issues, and the chief executive was agreed to come back in writing with what we discussed effectively, and what was been circulated to members just a few minutes ago is that response in writing from the chief executive following that meeting.
Okay, thank you. That's very useful. So we'll try and bottom it out a bit more. But I thought it was quite interesting because I knew part of the reason it was prompted was I knew you'd had that meeting and I'd had approaches as well. So, however, item 6, urgent items. I haven't been advised of any urgent items. So item 7, any declarations of interest on the agenda today? That's good. Item 8, I'm assuming there are no declarations of the party whip. And item 9, we have no petitions presented. So Standing Order 33. So we'll move on to the first substantive item of the day, which is the Health Watch Leicestershire discharge report on reports around improving hospital discharge even. It's going to be presented by Fiona Barber, Vice Chair of Health Watch. And to help with any questions, we have Sarah Taylor, Director of Urgent and Emergency Care at UHL, and Kelly Wright, Head of Service Home First from our own adults department here at the County Hall. So over to you, Fiona.
Thanks, Chair. As Health Watchers previously reported here, under the 2012 Health and Social Care Act, we are required to carry out entry review visits to health and social care premises to gather views from members of the public who use health and social care services, also to assess the standard of local health and care provision with a view to making recommendations for improvement based on the views of service users. Today, Health Watch is pleased to share with this committee 2 of its recent reports that focused on discharge. The committee is asked to note these reports. The first report was an entry review report published in March 2026, where Health Watch visited 4 wards at the Evington Centre, Colville Community Hospital and Loughborough Hospital. All of these are managed by Leicestershire Partnership Trust. We've also, the second report is a service report published in November 2025, entitled Improving Hospital Discharge. Now, this report followed on similar work that Health Watch had carried out in partnership with the University Hospitals Leicester in 2019 and 2020. Both these reports are available on our website. So I think it's safe to say that Health Watch recognises that this committee has addressed the topic of discharge previously, and the work that we've published recently builds on those previous conversations. The Health Watch team is led by a staff member supported by a group of trained volunteers to carry out enter and view visits. So before I talk about the reports, I thought it might just be worth reflecting on what good discharge may actually look like. I suspect around the table, committee members have varying experiences of discharge, whether personal or family or as a carer. But generally speaking, the process of planning for discharge would begin as a patient is admitted. The aim would be a safe, smooth and fully supported transition from hospital back to wherever it is that the patient calls home. The patient should be leaving hospital with a clear understanding of why they've been admitted and what their current status is as they leave. They should have a complete list of new and continued medication, including how to take them, and an adequate supply, perhaps up to 7 days worth. They should understand also who is the primary point of contact going forwards, whether it's continued with the hospital or back to primary care and their GP, and also any necessary follow-up appointments. It would be useful for patients to understand any specific instructions on restrictions for them, physical activity, red flags to look out for, plus any specific dietary requirements necessary for their recovery. Patients also express similar requirements to the list that I've just read, which is more hospital and clinician-led. But one key theme from patients is wanting to feel involved and supported throughout the discharge process. I'd like, if it's okay, Chair, to start with a report on improving hospital discharge. The focus here was to evaluate progress since 2020. This is based on UHL. To assess whether key issues identified in previous reports have improved, to collect qualitative and quantitative data from patients and carers about their recent experience of hospital discharge, and to include the voices of patients, carers and family members to ensure that we get a comprehensive insight. To aid us, we had a survey which built on the questions that we'd used previously in 2020 and added a few more so that we could understand how things may have improved. So we also carried out a visit to the then discharge lounge based at LRI. We had quite a significant response to the survey. Well over 100 patients and carers gave us their feedback on their recent experiences, which was really useful. You'll see that the key findings are shown on the report for this committee, page 13 at paragraph 13. I think it's safe to say from a Healthwatch perspective that there are positives to take from the findings of the report, particularly the feeling patients had of being involved in some of the discussions about being discharged, the timeframes of discharge, and feeling ready to go home. Patients also took time to highlight the kindness, professionalism, and compassion of staff that were involved in their care and discharge. It's useful to note, perhaps, that 46% of patients rated their hospital discharge experience as either good or excellent. However, as you would expect, there are areas which merit continued focus. Particular key themes that arose under that title were issues with communication between staff and patients, as well as between services and departments. Now, we all know that the hospitals are massive. There are a huge number of patients. The discharge is a constant process, and it's never easy to keep tabs on what's going on. But certainly from a patient perspective, there were issues around that ease of communication and understanding the processes. Quite often there were delays in terms of medication being available to patients to bring out. That's not a new issue. It has been noted previously. And I know UHL have done an enormous amount of work, but it's still something that patients are experiencing and that's contributing to them not being able to easily vacate the premises and leave a bed for the next patient. I think it's safe to say that all of those issues are well known and have been addressed previously, but the feedback from patients and their carers is that they are still causing them some concerns. Healthwatch on that report made a number of recommendations which are based on the feedback that we've had that I've already shared with you. Those recommendations are clear in the report, and I know that UHL would want to talk through their responses to them. The report has been shared with UHL. They've passed comment, and that is also part of the report. Chair, I can pause there and through you open up for colleagues from UHL to respond to that report and any possible questions or comments, or I can move straight on to the second report, which is based around Leicestershire Partnership Trust, and we can do the questions and comments at the end, whichever you prefer.
I think I prefer to split them, to be honest with you.
Okay, in that case, we'll pause and over to you for questions or comments.
Any questions, comments on so far? What saw your hand, Mr. King, or did I hallucinate that?
You did hallucinate there slightly, Chair, but I'm very happy to come in there at your invitation. So thank you, Fiona, for your report. And I think what you've outlined is certainly what many of us receive on a regular basis, feedback from residents about their frustrations and concerns. If they're in hospital, it's very often for reasons that they've got no control over. It's a very turbulent time for people, their families, etc., etc. And getting out of hospital is usually the focus that most people have got. They don't want to see how long they can stay there, usually, in my experience. So that is something that getting out and getting the discharge back to your home and then kind of making all the adjustments in your life that you've got to make as a result of whatever you've been in hospital for is really, really important. Unfortunately, it doesn't look like we are, we're doing, it's patchy. I think that's probably the best I can say. And some of it's probably working very well in some areas, and in other areas, it's not working very well at all. And I think that's probably, Chair, I think what Fiona's report is telling us, and unfortunately it doesn't sound like we've made a lot of improvements since the last time. I'm not sure whether there's any metric that's measured how it's improved from previously or not, if it has indeed, but that's the bit I'd like to understand. Has there been any perceptible improvements in the experience of patients with discharge? I can only qualitatively, my experience is I don't think it has improved much. I think it's still very patchy. Some areas, I say, are excellent, and others, they're not very good and have room for improvement. And I think the problem is, Chair, that when you're not very well and you're in hospital, the last thing on your mind is to then make a complaint to the health service. And, I think that's one of the issues. People refrain. I mean, there are complaints, but I do think people also hold back, because they think that if they make complaints, certainly I've had relatives who've been in hospital and they say, and you've seen something that's obviously not right, and you think, well, we should raise a complaint, and they go, oh, no, don't wait to make a fuss, because then they won't be very nice to me if you make a complaint. And that's a worry. So I think, that's what I'd say, and I'm not quite sure how the health service is going to, and it's not just the health service, it's also about, housing adaptations, because people then end up spending longer in hospital, don't they? So I'm not really asking many questions, Chair, but I think I'm just saying, I think it's probably reflecting what we all have experienced at one time or another, or relatives or whoever. And actually, it's how do we get that improvement that we need to see, we all want to see, because, getting into hospital is generally not a very, if you go in through casualty or medical emergency, that is not a good experience, and you want to come out and have a better experience than when you went in, don't you? So.
Yeah, worryingly, I can remember the report 6 years ago, and I do remember medication delays was a big part of that one as well. So, Mr. Poland and then Mr. Whit.
Thank you very much for the presentation. In paragraph 13 of page 13, I noticed the second to last bullet point is only 16% of carers were informed of their right to a carer's assessment. That is very, very low, isn't it? So I guess my question is, why is it so low?
I agree. I'm surprised that it is so low in terms of their awareness. So I think carers are a big focus for us at County Council at the moment. We're just re-looking at the strategy. What I would say is our carers assessments are typically completed outside of that hospital environment at the point of review. So I think the focus here for us is actually that acknowledgement that you are a carer and that that support will come. So we have an early review team. Most of our discharges back home, they will see one of our adult social care staff within 2 weeks. It's 10 days typically at the moment. So I think it gives that person time to get home, stabilise, undertake that review. I think what that's telling us is that we're not for kind of giving people the information about recognising you're a carer, and there is that assessment to come. So there is that delay in recognising that support is available once that loved one's home.
Thank you for that. So just to clarify, we would contact these people anyway, even if they weren't informed about it. So this isn't something they have to ask for, because it might be one of those you don't know what you don't know sort of situations.
So typically our adult social care teams support complex discharges. So I don't know whether the terminology P1, 2 and 3 translates. So that's still on. Yeah. So anybody that's going home with a care package, anybody that's going into residential or nursing placement. So typically that's the cohort of people that we're working with. But what we do have now, I also support some of the preventative work. So people coming out of hospital without a care package, we currently have the RVS calling out and just check those wellbeing checks. So that's where that kind of recognition for carer support, those conversations are taking place, and then they come back into the department, and then they're allocated the staff to undertake those assessments. So yeah, there's two prongs to it really.
Mr. Whitford.
Thank you. Don't know if you'll like what I've got to say, but I've recently been a receiver of this service. I've been in and out of hospital 4 times with a serious complaint. And I found that the biggest problem was communication between all levels, doctors, nurses, carers, even the person pushing the wheelchair. And it ended up with me at the wrong hospital purely because of communication. That was just one part of it. And later on my proper discharge, which this comes into, there was no information given to me, no meds, and there was no involvement to me at all. I was just slung in an ambulance and took home, and I knew nothing. And the communication issues, it's clear, and I'm not one to avoid saying things, so I hope nobody gets offended by what I'm just about to say. But the doctor and the nurse eventually were falling out and arguing with each other and couldn't understand each other at all. And so they started arguing in Swahili in front of me. I did ask what language it was. And
Whitford, can I remind you, we're not here to discuss individual issues. We're here to discuss the wider thing. Now, you're right about communication. I accept that, but we don't need necessarily all the gory details, for want of a better expression.
I disagree, because I feel that you're not going to get the full story unless I tell the full story. And it is relevant, because I didn't get any questionnaire about the way I was treated. So, but I'll leave it there on that point. But I would like to bring up one more on this. On page 12, bullet point E, which says that the representatives are all diverse of the community it serves. Well, Leicester, and these hospitals were all in Leicester at the time. I mean, Leicester's 50% white and 50% non-white. I'd like to ask the question why on 4 visits, I didn't see one white person in anything. No white driver, no white nurse, no white doctor. How can that be a representative of the community? Thank you.
Chair, can I just interject there? The point reference to is part of the dictate given under the Health and Social Care Act of 2012 to Healthwatch to be representative of local people representing diversity of the community it serves. It's not specific to the discharge reports that we have in front of the committee today. Thank you.
Yeah, and also we're not here to discuss the ethnicity and makeup of the workforce of the NHS. That's a separate thing. Mr. Mullaney.
Thank you, Chair, and thank you for the report, Fiona. I mean, I noticed the key finding was 58% of respondents felt involved in discussions about their discharge. Presumably that's the combined figure for both patients and carers, is it, the responses? Just really your impressions of that figure. I mean, it is over half, but it still seems rather low. I mean, was it a surprise to you that only 58% felt that, or was it not come as much of a surprise to you? Because it does seem fairly low.
Thanks for using that as an indicator. I think it's probably indicative of the overall feeling of patients and carers around their experience there. In terms of the discharge process, being involved is really key to being part of what we talked right at the start of a good discharge. If you're involved, you understand what's going on, you understand the issues for you and what's happening to you, what's coming down the line, then I think the chances of having a successful discharge, i.e. you settled in wherever whatever your home circumstances are, and you're less likely to return for treatment or a resurgence of your complaint. So it's not particularly a surprise. And when you look at the individual feedback off the survey that we had, a lot of the carers particularly felt uninvolved in the discussions being taken place. So it is a balance of patients and carers, but I can't give you the exact figures from previously, but it is fairly steady compared with last time. It is a constant that people want to be more involved. They want to have greater understanding of what's happening with them and their particular circumstances.
Okay, thank you, Mrs. Knight.
Thank you. Discharging people to go home to get better, if that's not the case, I presume you've got a fast track process for getting people out quickly so they can get home, getting equipment out there. And I just wondered how many days is your fast track process for people going home and getting the equipment in there if you've got a fast track process?
Yeah, can I just check the question? So is this with those patients that are going out with equipment and supported discharge? Is that the ones that you're asking about?
I'm asking about people who are being discharged to go home,
Yeah.
who are not going to get better, but will need equipment in that home to fulfill their wishes.
Sorry, I just want to check just to
Yeah.
make sure we give you the right information, because if Kelly mentioned earlier about the P1 to 3, and there's different target ranges for those discharge areas. But our fast track patients, we would seek to discharge within 24 to 48 hours, particularly if those patients are on an end of life pathway.
That's brilliant. What about the equipment getting out to the home?
So generally, we do fast track the equipment. So we'll link in with the local authority colleagues, depending on what that needs, or whether it's equipment that's being provided by the hospital, and aim to have that out and in place within 24 to 48 hours. Whether that's patients receiving a more intensive support package within their own home and therefore need equipment to be able to be safe there, or whether that is they're going to a placement and therefore need equipment within that placement. So 24 to 48 hours normally for those patients on an end of life pathway.
Thank you, Mr. Piper.
Thank you very much, Chair. I was just going back to, first of all, may I say, I've had two, I nearly said very pleasant stays in your HL hospitals, in one in each of two different hospitals. Going back to the key findings, I think that some of these figures, as some of my colleagues have already mentioned, are disappointingly low. And I wonder whether or not, because these are subjective of how the patients and the carers feel afterwards, whether you feel as if they have misunderstood the situation, and in fact the information, etc., that they've got was actually better than they perceived. Or how much of it was actually just not been given enough information. Thank you.
Yeah, thank you. So I think just to start off the answer to that, I really welcome this report. For us, it's an opportunity for us to learn, take feedback and reflect and make improvements, albeit there is always work to do in this arena. I think the point for me is that patient or that carer felt that way. So whether we think they got the right information or not, clearly to them they didn't, and I think that's the most important thing that we listen to. So we have made steps. We've developed information leaflets that gets rid of jargon from, hospitals are like, we're full of jargon and acronyms and all the rest of it, but describes the kind of language we use, the process that we're going to go through, the way that we want that we're going to communicate with people, and that is given, as well as a range of other information. And local authority colleagues have followed that with then a discharge leaflet, so that it knits together. But for me, these patients who responded that they didn't feel involved felt that way and have reported that way, and that's the most important thing that we need to listen to.
Thank you. Now we've got Jewel Meir, who's virtually here, so he's got his hand up. Jewel, do you want to come in?
Cheers, thank you, Chair. Thank you very much, and apologies I can't be in the room with you today. I just want to pick up on the 3/4 feeling unsupported when they got home, and I know people have touched on it, and how we can do better to let people know what support is out there, maybe at the early stage when they're being discharged, or so early on when they're at home, because that must be a time of real worry for them when they're, they've just come out of hospital and they're not sure what help or access they've got. So what are we as a county council or as an authority doing to let people know what help and support is available to them?
Yes, so going back to the supported discharges, we were saying, I think for the last 2 to 3 years, our staff have actually been back on the wards. So, this should be the cohort that are actively being, kind of brought into those discharge discussions. Now, I will say that we are aware, having run our own exercise similar to this, that the literature, the hands-on care planning and the assessments don't usually get provided in hospital. So actually, I think something where we can actually give that person their care plan, the contact details for the provider, estimated call times, I think would go a long way in that reassurance. And again, making sure that carers are aware of what's to follow, that very quick turnaround in terms of review. They shouldn't feel that they're on their own, for that first, 24, 48 hours. There should be phone calls that are taking place and offer that reassurance.
Yeah, and I think we need to recognise that within the group of patients that have been surveyed and interviewed as part of this, there will be patients within there that don't go home with a supported package, which is equally as important that then the UHL obviously take responsibility in terms of that last point, in terms of how we provide patients with information, and some of that links back into 71% received a copy of their discharge summary, and there was some accuracies in there that discharge summary points people to what to do. But it's not about just printing it in a letter. It's about that conversation with the patient at the point that we're discharging, that, these are your meds. This is what you need to do, and here's some verbal information, and then we've written it down as a follow-up. So part of the work that we've been doing is the patient and carer work, which is around an education programme across our wards. We have staff turnover. We have new staff starting every year with people coming out of colleges and universities. So we've got an iterative education programme, and we use reports such as this. We use patient feedback from message to matron feedback, albeit through the complaints arena, and we feed that into that education programme, because I think all parties across health and social care need to play a part in the key findings of this report in order to support improvement.
Yes, thank you.
Okay, thank you. Mr. Smith.
Thank you, Chair. You've actually just sort of semi-answered it, but what I'll do, I'll just, if I can, just expand on it slightly, and it's about point H, where you signpost people for information. again, I'm quite fortunate. I don't go hospital very often, and if I do, it's tend to visiting people. But a recent family member was in hospital, and they received several pieces of information on the discharge, but it was all conflicting. And this is something that, you know, a lot of people and residents have said to me, that the information that they get, whilst thorough, is often conflicting with verbal information that they may get, or a text message or a letter 2 weeks after their discharge contravening what they've actually just said. So I wonder if you can clarify if there is like a single signposting point.
We do have a single signpost because we have a patient advice service that can be a point of contact for patients. I would reflect on an experience where I was with a patient recently receiving some feedback. And for me, that patient had their discharge letter in front of them, and the nurse was reading from the discharge letter. So the verbal information that she got was exactly as was printed in terms of that conflict. Now that's really good practice. And what we need to do is make sure that when through our education program and our education sessions, that we are encouraging that kind of really good practice, so that then there isn't that conflicting advice, as well as to say to people, and if you're worried, here's who you can contact, etc., etc.
Thank you. And finally, Mr. King.
Yeah, thanks, Chair. So a couple of questions I've got. So first of all, just looking at this report from Healthwatch, just wondering, the other feedback systems that the NHS and ourselves have, does the kind of overall trends, the feedback we're getting from this report, is that comparable to the feedback and, you know, data that comes in from other systems? It is a relatively small data set, and I also noticed that 40% is referring to discharges that were in 2024 or late or longer ago. So some of it is quite historic, and that's obviously, you know, it's kind of, in some respects, quite hard to know how much. I mean, you know, I'm not disputing it in some senses, but it's equally quite a small data set. And the only other thing, obviously with the data, I mean, it does seem to be very predominantly relating to the major hospitals. That's the General, Royal and Glenfield, less so the community hospitals. Very, very low response from those, even though I know there's, you know, their throughput of people is quite. So I'm just wondering how, you know, how can we draw much from it, depend on it, if the data is not very large, or, you know, and the only other thing is this data across the city and county, or is it just county specific residents in the county? Because obviously we're only looking at the county, but if it's a joint report, then the only thing I would then say is the demographic of those people who've declared is not representative of the demographic of the city and county together. So I'm just kind of, again, I'm just trying to understand how much reliance we can put on it if it's not as representative as it, you know, of the population that we're serving, basically. Thank you, Chair.
Let Mrs. Barber address those points.
Yes, thanks, Chair. In terms of the report, this report was published in November 2025. It had been through the process where Healthwatch sends the draft report to UHL for comments and what have you. So yes, the data does come from 24 and early 25 to feed the information. However, when you set that against that, this is following on from similar exercises in 2019 and 2020, you have themes and trends that are consistent right across the years. The percentage points might go up and down slightly, but the themes in terms of communication, support, delays to discharge, medication are the same, very similar. And I think colleagues from UHL have worked really hard in terms of trying to address some of those with some success at some stage. And it's not a constant straight line. It does go up and down dependent. Is it a small sample? Well, compared with the number of patients that go through UHL, yes, it is. But don't forget, of course, the county patients also go outside of the county. We have people here who've experienced George Eliot, for example, and QMC in the survey. But the majority of them are people from the city and county, because we can't separate them out on this particular survey that was done back in 25 and 24. We can't separate them out, but they are indicative and follow the trend of previous reports. So I think in terms of interpretation, you can take the flavour of what this report is giving it and set against the work that's been done at UHL, and you get a really good sense of the issues behind the discharge process and can work with that. In terms of community hospitals, the report highlights, and my next report is around discharge at the community hospitals. So when we've finished this particular discussion, I'll move on to that.
Well, I mean, there's no other speakers, so do you want to move on to?
Yep, I'm very happy to. So the second report, sorry.
Sorry, I just wanted to add a little bit to that. So absolutely, UHL discharges circa 10,000 patients a month. So in terms of the volume of patients that goes through, broadly 5 to 6% of those patients will go out on a pathway. I think I haven't got the data comparison with me to say, yes, our data recognises that 58% of patients didn't feel involved in their discharge. But what I can tell you is I recognise the themes that are coming through in the Healthwatch report in relation to the themes that we look at in terms of the trends that comes through on our internal reports. As I've said, message to matron, feedback, complaints, etc. TTOs obviously are in here, and we've already referenced that they have been in here for a number of years, and we recognise that they're a challenge. It can be quite a complicated process for patients around their take-home medications, and equally it can be quite a simple process. So there is work taking place and will continue to take place within UHL in order to improve that. And we are going to try some different things as we go through later on this year about having junior doctors within our discharge lounge that we're creating at the LRI, etc. So we will continually strive to improve in that area, recognising that it is a challenge.
Mrs. Balmer. Thank you, Chair. The second half of the presentation this afternoon relates to enter and view visits at 4 wards across 3 of the community-based hospitals around the county. So colleagues visited the Beechwood ward and Clarendon ward at the Evington Centre at the General. We also visited the Thrinxton ward at Colville Community Hospital and Loughborough Hospital, Charnwood ward. So those wards contain a mixture of patients. Beechwood ward is a female-only ward. Clarendon ward is a male-only, whereas Thrinxton and Charnwood are both mixed wards, obviously with separate bays, but mixed. So colleagues took the time there to gather patient views of the service at each location, which included elements of discharge, observing the facilities, operation of the service, and to try and understand the process going through. So in general, this was a much more positive outlook. Key findings here included positive experiences around calm environments, strong multidisciplinary working, and good patient satisfaction. The recommendations from the Healthwatch team, enter and visit team, contained some issues around the provision of equipment in the wards, the food and the diet issues. But it also pointed out that patients should be consistently involved in decisions about their care and discharge to ensure that they clearly understand their options. And their good practice should be shared because, of course, the community hospitals are spread throughout the county. So what's good practice at one should be shared across the estate so that we can promote independence, meaningful activity, and also coordinated discharge planning by embedding that good practice across all the discharge wards. So I think it's safe to say that the community hospitals are a much calmer environment maybe than LRI. The throughput is significantly less numerically patient-wise than LRI, and it may be that's reflected in the feedback that we received from patients and their carers, and that report is also for noting, Chair.
Any specific questions on that report, or are we just happy to note it? So I'm happy to note it. Thank you very much, Fiona. It was very informative and interesting. We will, and thank you to Sarah and Kelly for coming in and being grilled by people. We're now going to talk about the Learning Disability Annual Health Check. It says here this report's going to be presented by David Williams, Group's Director of Strategy and Partnerships, LPT. He isn't here. He's got the CQC in somewhere and run off to talk to them. So we take second billing to the CQC visit. Instead, we've got Laura Rodman, who's the Service Development and Manager of the Learning Disability, I think it's Alliance Collaborative, sorry, who've done a lot of the good work here. So we'll just let people rearrange the seats, like get chairs on a certain vessel. Oh, right. Yeah, you get chair. Oh, right. Well, there you go. You see, you live and learn. Yeah, thank you. So when you've sorted yourself out, Laura, we'll hand over to you and you can tell us about this report. I shout quite at my laptop, which I've broken.
Hey, thank you and good afternoon, everyone. As mentioned, unfortunately, David Williams does send his apologies this afternoon. I'm Laura Rodman. I'm the Service Development Manager for the Learning Disability and Autism Collaborative across Leicester, Leicestershire and Rutland. And I'm here today to provide an update on annual health checks for people with a learning disability. And the committee are asked to note the content of the report today. If I may, I want to start by sharing a patient story with you all. I think it really demonstrates the fundamental importance of annual health checks for individuals with a learning disability and the really significant impact that they can have. So one of our primary care liaison nurses was contacted by a GP practice to support an individual with a learning disability. They had a history of limited engagement with healthcare services, which posed a real barrier to that timely assessment and intervention. And there was concern that he was presenting with significant unmet health needs at this point and would benefit from an annual health check. Initially, the primary care liaison nurse undertook a review of his medical records to inform an appropriate engagement approach with this gentleman. Multiple attempts were made to make contact with him, which did include home visits at varying times of the day. However, unfortunately, those initial efforts were unsuccessful. Pleased to say, however, that contact was eventually established with the gentleman and he agreed to a scheduled home visit at a time of his choosing. So at the initial visit, they did demonstrate some reluctance to engage in the health check process. However, it was really important the primary care liaison nurse used a person-centred, supportive approach. They were able to build that rapport with the gentleman and he was enabled to participate in an annual health check. During the physical assessment element of the health check, he disclosed that he was having difficulties removing his shoes. Further assessment revealed that he had severely ulcerated lower limbs. This wouldn't have been identified without the health check, and it indicated a significant deterioration in his physical health. Given the level of clinical concerns that were raised, the primary care liaison nurse liaised promptly with a GP practice who agreed to assess the individual. Again, there were concerns around the individual's anxiety and their reluctance to attend healthcare settings independently. So the primary care liaison nurse provided support and accompanied the gentleman to attend the GP surgery. With the support in place, they attended the appointment successfully and they remained settled throughout the examination. The clinical findings raised considerable concerns regarding a possible infection and suspected deep vein thrombosis, which would require an urgent secondary care assessment. However, recognising that the individual would be unlikely to tolerate a very busy accident and emergency environment, and there was a real risk they may disengage prior to that assessment, the GP and primary care liaison nurse collaborated to develop an alternative plan. So they arranged a direct admission pathway for the individual at the University Hospitals of Leicester to minimise distress and also reduce the risk of him leaving without having received treatment. In terms of the key findings from this health check, I think the role of the primary care liaison nurse, they played a key advocacy role for this individual throughout their care pathway. And that included coordinating directly with the receiving clinic prior to attendance, ensuring he could attend. They arranged a quieter and less stimulating waiting environment for the individual. They supported them during admission and assessment, and they remained with them until a treatment plan was agreed. And I think it's really important to note that these reasonable adjustments were essential in ensuring that he engaged and was able to access care and safely, effectively. In terms of the outcome for this individual, with the support from the primary care liaison nurse, they were able to access urgent secondary care services. They remained engaged throughout that clinical assessment, and then they received a treatment plan for their infection and the DVT. And just to note as well, the individual was only left in the hospital once appropriate adjustments were in place, and the hospital staff were fully informed on how to meet their needs during that visit. The case really highlights the critical role of primary care liaison nurses in annual health checks in engaging hard-to-reach individuals, facilitating equitable access to healthcare through the annual health check. And I think it really emphasises the importance of persistence, flexible care planning, multidisciplinary collaboration, particularly when working with individuals who experience barriers to engagement with healthcare services, such as those with a learning disability. And tailored interventions and advocacy were key in achieving a positive outcome for this individual. So this is just one individual story I wanted to share with you today. And there will be so many more of these stories across the 5,347 people who received an LD annual health check last year in LLR and the previous years. And in fact, our primary care liaison nurses are preparing other patient stories related to annual health checks. And these will be published during LD Awareness Week, which is week commencing the 15th of June. And they really focus on the theme, Do You See Me? And they've shown how they see people through the health check process. But I think for me personally, this patient story really highlights why, as a system and a collaborative, we are continually seeking to increase the number of people on the LD register and also improve access to annual health checks, which play a vital role in ensuring timely and appropriate treatment, improving health promotion, and reducing health inequalities for people with a learning disability. Just drawing your attention to the paper, within the paper there are several projects and initiatives taking place this year. They are specifically aimed at increasing the number of people receiving an annual health check, and that's all ages. We've got enhanced monitoring of people who either did not attend or was not brought is a code that we use. So this is for individuals who are living in care homes, for example, residential care, and aren't brought for their health check. And looking at where appointments were declined as well, and that has enabled targeted support to provide to both practices, how they can support those individuals and the individual themselves. We're also looking at how we can increase uptake of annual health checks amongst people aged 14 to 19. The LD register is 14 plus. We have identified that attendance is particularly lower than other age groups amongst 14 to 19-year-olds. So linking in with SEND services, educational services, and making sure those individuals are on the LD register. And finally, looking at how we can improve the quality of annual health checks and also the health action plans that are produced following the health check. And I think the collaborative's efforts to make sure that our targets are stretching, so we're continually stretching our target in terms of how many percentage of people we want to achieve a health check, they remain achievable, but they've really allowed the primary care liaison nurses to focus increasingly on the quality of the checks across LLR, and also the creation of health action plans to support that continuity of care and improved health outcomes. So just to bring us to a conclusion, the report you've received and also the case study that I've presented to you today, I think it sets out the need for that continued support to ensure people in LLR with a learning disability have access to a high quality annual health check. The sustained high performance of the collaborative's work, which we've achieved through rigorous and impactful project management. We've developed mature system-wide relationships, and as we've been able to establish really strong, robust process for annual health checks, that's been recognised regionally and nationally. And I draw your attention to the section on the combined annual health check pilot in the paper. It was a national pilot we're invited to be part of, and the learning that has presented to us as a system. It really sets out, again, the balance being sought, as I mentioned, between stretching our targets and the developmental and high quality intervention. And finally, any comments or thoughts on the activities, progress and plans that we have in relation to annual health checks are welcomed. Thank you, Chair.
Thank you. I remember it wasn't that long ago. These figures were awful. So this is really good to see. Mr. Poland and then Mr. King.
Thank you, Chair. Thank you for the presentation. Actually, I think it was one of the last things you said there regarding the pilot, with the pilot area for delivery of an autism health check. Just to forgive me, is this as much stupid question? I'll just ask it. Is this to check whether people have autism, or is this for people who have autism or qualified to have one of these health checks?
Yeah.
If it's the latter, is it everyone that has autism, and how do we identify that? Because obviously, I'm not aware that we have a register or anything of those that have autism.
Yeah.
I have this in my family, so I've first-hand direct current experience of this. And as I say, I just sort of I didn't know this was a thing until I read it. So how do we let families know?
Absolutely. So we were invited to be part of the national pilot, and it was testing if it was feasible to combine the LD health check, which is currently operational, the SMI, so severe mental illness health check that is currently operational, and bring in an autism element if you had an autism diagnosis into one combined check. So at the moment, if you have LD, you're called for your LD health check. If you have severe mental illness, you're called separately for that. So you've got potential duplication of appointments, the individuals being called in for 2 appointments rather than 1. So we developed a template that covered all 3 elements. There was a lot of overlap, as you would expect, between the 3, but we co-produced that to make sure it identified the specific autism, SMI and LD elements within that. It was a national pilot. We had to complete 500 checks. So we went out to practices across LLR asking for expressions of interest. We achieved that target. The key thing from the pilot, though, is there is going to be an independent evaluation report published imminently. That's then being taken forward by NHS England to inform future discussions around the GP contract, for example. But you are right, there is no, at the moment, autism register. There is no operational autism health check. That is going to take a number of years, and NHS England have been very open about that. As a system and a collaborative, what we're wanting to do is take forward all of the learning from the pilot. You know, we've learned a lot being part of this pilot, and it's highlighted 2 things for us, really. At the moment, if you have a learning disability, you are called for a health check, regardless of the diagnosis and other long-term conditions. The individuals who are autistic that we identified for the part of the pilot, a lot of them lived very successful, happy, you know, they didn't necessarily need that level of intervention. So we are rolling out from September another pilot, which is more of a targeted health check for autistic people. It is local to LLR only, it's not something nationally. And what we're wanting to do is offer that health check to people at very defined points in their life. So, for example, if you're transitioning from children's to adult services, we know that can be very difficult for some people. Those that have previously been admitted into a mental health hospital who are autistic, those who are on the dynamic support pathway, which means they need that multi-agency intervention. So it's not available at the moment. It's testing, is it feasible to roll that out? And we've obviously fed our learning into the national team through the evaluation process.
Yeah, that's useful. Thank you. I assume that the people who have been contacted so far have been done through, as you say, through their GPs, and that would make sense as the way to do it for adults. If it's rolled out more generally, I would encourage you to think about maybe doing it in addition through schools.
Yes.
That's certainly how my son has been going through this process, basically, and primarily through schools, and GPs had some involvement, but mostly this has been about schools, and so that would be a good way of getting the children.
Yeah, definitely. Thank you.
Thank you, Councillor King.
Thank you. Laura, thanks very much for this. So, I mean, it's a kind of similar line to Mr. Poland, although not exactly the same. So the first thing I wanted to try and understand is the LD register that's mentioned. What's the definition of the LG register?
Yeah.
Who decides who's on this LD register? You know, what's the severity of someone's disability that so first of all, whose register is that?
Yeah.
Is that the health service register? Is it social services register? So that's the first point.
Yeah.
Second point is then picking up this autism thing. Now, I also have a lot of experience of this family member situation, and you're right. A lot of people what they can describe as high functioning autistic. They're intellectually very able.
Yeah.
All of those things, but they're actually not one of the problems. And everyone's an individual, so it's difficult to draw, you know, to say everyone's like this and everyone's like that. It's not as simple as saying someone's got a broken leg. That's how you fix it. So it's not as easy as that. I know that, but there are some clear problems, and one of the problems is communication. So when you communicate with someone who's high functioning autistic and say, you need to come for a health check, they say, oh, I'm all right. Nothing wrong with me. But it could be that one of the things they do is that they, when they're anxiety or when they've got stress or when they've got other kind of, you know, their autistic, their neurodiverse symptoms is that they might overeat, for example, and so they become obese, but they may not recognize that. So they may not recognize they've actually got a long-term health condition. And they may also, because of that, they're not engaging with their GP, they're not engaging with any health service, and you can't make them because they're not incompetent, they're not classed as that. So it's incredibly difficult. So just saying GPs are going to ask people to come, I mean, I think that's going to, so I'm interested in this pilot, but I think one of the dangers is that, and I think it's different when you've got younger children and, you know, they're still under the parents, carers can kind of take them to appointments and make them go, you know, I say make them, but you can actually do that. You're actually able to facilitate that. But when they're kind of adults and, you know, you can't do that. If they say, no, I'm not doing that, you can't make them. So what I'm interested in is how you're kind of looking at that in terms of, aside from the LD stuff, and I know there's a lot of crossover with these things, but if we're talking about people who are high functioning, and one of the other problems with people who are autistic on the autistic neurodiverse spectrum is they're much more likely to not be working. You know, 80% of them won't have either a part-time or a full-time job. That's you know, these stats. And that's even more concerning because actually they're not going to be particularly active in the environment. So I'm just wondering, you know, as I say, this autism health check, it sounds great, but I think there are some real problems with delivering that. And the biggest problem is getting autistic people to actually engage and understand that actually they need to do, you know, how are you going to get them to do this? And this is the problem, because I know from personal experience that you can't.
Okay. Yeah.
Especially if they're not engaging with any health professional for all sorts of reasons, because their perception is there's nothing wrong with them.
Okay.
So I know it's a bit of a long ramble, but I just kind of thought it's important to get this on the record, because this is really, so the danger is for me is that you're still going to get a lot of people falling through the cracks.
Yeah.
And it's only people who are actively, you know, engaged, or they've got their parent carers, or they're that severely impacted that they do need ongoing support. But it doesn't mean that a lot of people who are out there don't also need input. And I'm just wondering, that's the question really.
Yeah.
Sorry.
Yeah, thank you. So in terms of the LD register, it's held by individual GP practices. So there's it's all done through SNOMED codes. Essentially, they get coded as having a learning disability. That is managed by the GP practice in conjunction with the primary care liaison nurse. So every year they carry out what's called a validation of their LD registers. There are 4 primary care liaison nurses. They have their own practices that they have really good relationships with. They will go and look at the register and say, yes, that person meets the criteria, or no, they don't. So it's very much based around your IQ, having that formal diagnostic process. But really for us, what we're looking to do is increase that register around 2% year on year to make sure that everybody, and as I mentioned earlier, those that are 14 plus, particularly 14 to 19, making sure we're linking in with social workers as well. We go and attend the LDA managers meeting regularly, and we're continually saying, you need to think about, is this person you're supporting, do they need to be referred to be onto the LD register? So it's held centrally by the practices, and it's very much about making sure that everyone that is eligible is on there, and then they're invited to their health check through that process. Does that answer the question?
Well, it answers that question. But what you're saying then is LD is someone needs a definable diagnosis that they've got a learning disability, so they're neurologically challenged.
It
basically
needs to be a learning disability, yes.
Yeah,
So they're
that's
it can't be the learning difficulty or global development.
Yeah. Okay. So coming back to the autism, then, and specifically those people who aren't, shall we say, actively engaging with medical or social care professionals at the moment, how is this autism health check going to kind of get to them?
Yeah.
How are they going to recognise they actually need a health check?
We experienced exactly that through the pilot. So we co-produced with an autistic person. I know you meet one autistic person, you've met one autistic person, but we co-produced with them the invite letter to essentially outline why they were being invited for a health check. And we had a high did not attend rate amongst autistic individuals. So we recognise it is a challenge. Like you say, there are some people who won't recognise they need that support. For us, this is a very small local pilot. We've fed everything you've said, we experienced through the pilot. We've fed that into the NHS England national team and said, if you are going to roll this out at a national level, these are the challenges you will have. You need to have really clear communication as to how this will benefit autistic people. We need to be really clear why we're asking people to attend. So I'm not saying we have the answers at the moment. It's something that we're testing, we're working it out. And that's why we're taking that phased approach. So people that have been previously had admissions into inpatient mental health hospitals, for example, we need to support those in the community, making sure they're, no longer needing to be admitted. So it's that phased approach, because we do recognise it is a huge challenge. And as I've mentioned, every autistic person is different. Some will want to engage, some won't. And we need to make sure they're given all of the information that they need to make that informed decision.
Autistic people can decide they don't need to go for exactly the same reason.
Exactly.
They're still competent adults. Yeah. Mr. Smith.
Thank you, Chair. This is almost like a follow-on here. You say that obviously every person with a learning difficulty gets offered an annual health check, and then you say that the uptake between 14 and 19-year-olds is significantly lower. Now, this may be a stupid question. I just can't get my head around this, particularly the 14 to 18-year-old. As a parent, as a carer, as a school, why can we not enforce it?
We're just not able to, like we've touched on, just because you have a learning disability, you may or may not have capacity to make that decision yourself. So if somebody has capacity to say, I don't want to attend my learning disability health check, we can't enforce that. We can encourage, we can make reasonable adjustments, we can invite them, we've offered them at locations that aren't health badged, because we know that can sometimes cause anxiety. It's about making that reasonable adjustment. So we do home visits, we do offer everything we possibly can. But if somebody has capacity, or I think you've touched on the point when it's parents who are making that decision as well, we can inform parents and we can share the information, share case studies, benefits that are identified through that. But it's not something we can enforce. It's something we strongly encourage and communicate and offer reasonable adjustments, but it's not something we can enforce, unfortunately.
So, again, as a parent, if somebody, a clinical professional was telling me that this is what your child needs. Why would I choose not to do that? What
I don't think I can answer that.
Yeah,
Individual
that's what I can't get my head
yeah,
around. It
yeah.
makes no sense to me. But
Yeah.
yeah.
They tend to fall into what we call the was not brought category. So if you're, obviously, I've mentioned if you're in a care home or if you live with your family and they don't bring you to that appointment, if you're unable to take yourself to that appointment, you fall into the was not brought. And we've done a lot of work to understand what are the reasons behind that. So is it the fact that parents may not understand the benefits of a health check? You know, some people, not necessarily in the 14 to 19, but we know that some people with learning disability may live at home with their elderly parents. We know there's issues around uptake of screening for those individuals as well. So, you know, we're encouraging the individual where we can, but we know we need to work with the families as well to encourage them to attend. But it's something we've recognised, and as you say, we're linking with education in particular to make sure that anybody who's identified through the SEND work, anyone who's got any HCP, for example, you know, making sure they're on the LD register if they need to be.
Thank you. Mr. Whitford.
Thank you. Thanks for the report. I have a son who's now he's been diagnosed through a visit, a health check. Wasn't yours, unfortunately, but I appreciate what you're doing. But he was at that health check. He was found to have a health problem that he wouldn't admit to. And my simple question to that is, carry on doing what you're doing, please. But could it be possible, I know it's early days, that it's not an annual, but maybe more often?
Interesting question. Yeah, that's something that we'll absolutely take back and consider. I think because it's done in primary care, it's alongside a lot of other things within primary care. This is my individual answer, my personal answer. I would imagine there'll be a bit of pushback around capacity in primary care to do that. You know, it is a funded health check. They do receive funding to do that. But you'll notice in the infographic, I think it's figure 2 in the paper, what we've really tried to do is it was seen as like a end of the year process for somebody, because you would hit the funding requirement then to get. So what we've really pushed is them happening earlier in the year, and you'll see from the infographic that shift has happened over the past few years. It's something we will absolutely ask, but I think we will get pushback from primary care around capacity. We'll absolutely consider it. Yeah.
Thank you, Mr. Poland.
Thank you. Just a follow-on comment really from Mr. Smith's question and comments in terms of the parents bringing, you know, like you, I can't imagine that you wouldn't take up whatever you want, you know, what's best for your children. More of a comment than a question, I suppose, is, again, from personal experience, if you're asking the parents to do something, that's great. And, you know, I would certainly do whatever I can for my son. But if we're doing it where it ends up being, I mentioned before about in schools and things like that, so you're going directly to do that. They already do certain vaccinations and things in school. And as a parent, so my son's a primary school age child, okay, and where they ask you permission, so will you consent to it? Yes. But then for about 3 or 4 years, you then got a letter back going, oh, we couldn't do it because your son said no. And it's like, what do you mean my son said no? He's 6. I'm saying yes, but he's saying no. So, you know, I thought that, again, it sort of feeds into what Phil was saying as well. You know, it's that I don't want it, and because of the condition, I'm not doing it. And it's, you know, I think it was just God Almighty for me, if he'd have come back without having his vaccination last year, that eventually made him do it. But I guess it's just offering that thought that parents bringing children is one thing, and parents giving consent and then to it being done in the third location is something else. And again, it's perhaps something to think about, feeding into my colleague's point.
Okay, we've got no further speakers. That was really interesting. Thank you. It's a good news story, and I'm pleased that eventually things might get rolled out a bit more to other groups.
Yes,
because you've clearly got you've thought about it. You've got a way it works. You're learning from it. So yeah, more power to your elbow. Thank you very much.
Thank you very much. Thank you, everybody.
Yeah. We now turn to Vaccines and immunisations. Well, hey, this is another thing where people decide not to do it. We won't go to that part of the world at the moment. So to present this, we've got Sean McGill, Assistant Director of Public Health and the County Council, Emma Burns, Strategic Lead for Health Protection, also at the County Council, and Dr. Naomi Caldwell, Deputy Chief Medical Officer at the Integrated Care Board. And I'll give Sean time to scuttle around and see you're introducing it. Do you want to go and join them? Yep. Mr. Harrison, who's the lead member, is also going to go and sit on the front row to swell the ranks. Whenever you're ready, Sean, you can talk about the report. Stop breaking my technology.
Thank you very much, everyone, for having us today and for the introduction. So we're working together as Public Health at Leicestershire County Council, along with the Integrated Care Board and Naomi on this presentation. So Naomi is going to start us off.
Thank you, Sean, and hello to everybody. Thank you for the opportunity to come and talk to you today. My name is Dr. Naomi Caldwell. I'm a GP in Northampton. I work now across Northamptonshire and LLR as we've clustered together as ICBs. So this is not my geographical area, although I am learning fast. And I've had the help from Sean and colleagues on that. So we've come today to give you an update on VAX and IMS in Leicestershire. We will take the paper as read. I'm just going to give a bit of a brief overview and then I'll hand on to colleagues. Vaccination and immunisation services are commissioned and delivered in line with national NHS policy and guidance, which includes the UK immunisations schedule. And that's what we refer to as our Green Book. You may have heard that during COVID times, the Green Book was talked about a lot. There was a particular chapter, chapter 11, which is you can Google and you can find it, and it gives you that UK immunisation schedule, and also guidance and advice from UK HSA, which is the UK Health Security Agency, and you might again hear that referred to as UXA. I think someone mentioned previously we're very good at jargon and acronyms in the NHS, so if there are any that you don't understand, then please ask. So vaccinations are provided through a mix of providers, including general practice, community pharmacy, maternity services, and what we call SACE, or school age immunisation services. And then there are additional resources in the form of mobile clinics, super vaccinators, to name a few, which you will hear about a bit later on. So the life course of vaccination refers to the full range of NHS recommended vaccines delivered at different stages of a person's life. And again, you can find that in the Green Book, and I think it's also detailed in your pack in terms of the different ages and what vaccines are offered. We tend to group it into sort of age ranges, so pregnancy and early years, particularly in pregnancy, things like whooping cough vaccination, RSV, which is respiratory syncytial virus and can cause things like bronchiolitis in young babies and pneumonia. Early years, we have the early years schedule, polio, diphtheria, meningitis, MMR, so measles, mumps, rubella, but there's also the V that's added on now, which is varicella, and that's chickenpox, so that's come in at the beginning of this year. We then move on to childhood and adolescents and young adults. Again, different vaccines at this stage, so HPV, human papillomavirus, of which particular strains have strong links to cancer. A different meningitis vaccine, so A, C, W and Y. And in this, there's targeted catch-up for these individuals as well. So again, delivered by general practice and in schools, but also the ability to catch up individuals who may have missed them. Working age adults, particularly long-term health conditions. So we know about things like asthma, diabetes, you're eligible for a flu vaccination, but also some neurological conditions. So people who have multiple sclerosis, for example. So there are other conditions where you are eligible for a flu vaccine. And we can also work with employers in this space, and GP is a big provider of vaccination for that cohort. And then moving on to older people, the flu vaccine for the over 65s, the spring and autumn campaigns for COVID-19, which is a very specific cohort now. over 75s, care homes for older adults and those who are immunosuppressed, pneumococcal vaccine to protect against pneumonia, and a shingles vaccine in that older age group. So vaccines are not a one-off intervention. There are important differences between those that are given as a course for lifelong protection, and then there's also the seasonal vaccines. We know we heard a lot during COVID about variants. There are ever-changing flu and COVID-19 vaccines to tackle these variants. So the components are reviewed each year and the vaccine change slightly each year. So essentially vaccination across the life course remains a core public health intervention in Leicestershire, and it's locally delivered and overseen by the ICB. I think it's over to you now, Sean. Thank you.
Thank you, Naomi. And then, as we would perhaps expect, given the breadth and complexity of the vaccination landscape, as we've just heard, uptake is not uniform across our communities. Instead, we see differences not only between different vaccines in their uptake, but even within a single vaccine programme, we see differences based on communities and populations. These do tend to follow some common trends, though, which are highlighted in the report, with these including deprivation. So we know that national evidence shows that people living in our most deprived areas, which for Leicestershire would be some areas within Charnwood, North West Leicestershire and Wigston. National data shows that if you're in the most deprived areas for flu vaccine, children can have around uptake of about 30%. And then if you're in the least deprived areas, that could be 53%. So that's a big difference that we see there. We know things like rurality can also be an issue because it can be that much harder to go access a location for a vaccine. If it's a 5-minute walk to your pharmacy, then you might be more likely to do that than take a 40-minute bus route to a location. So rurality can be an issue. Ethnicity as well, looking at different ethnicities, we see differences in uptake. So again, national evidence, because we don't have the local data, because you start going into smaller numbers and it's harder to analyse. But when you look at the national picture, you can look at these things. National evidence shows that with COVID-19 vaccination, we have reduced uptake in Bangladeshi and Black African populations, for example. Even just gender, so with the HPV vaccine, which was historically just given to girls in schools, and then it was extended to cover boys as well. Since that was happened, we've seen consistently boys having a lower uptake than girls in schools. We also see differences within one vaccine, which have a course where you might have multiple vaccines rather than just a single one-off. So the meningitis B vaccine, for example, needs 3 doses. With the first dose, we see an uptake locally of about 95%. At dose 2, that's then 93%. And then at the booster and the final dose, that's 87%. So when people need more, it's sometimes trickier because you have to have lined up everything for the first one, lined it all up for the second, and then the third as well. So there are more cracks for people to fall through, as it were. And we also see differences based on the eligibility of someone to have a vaccine. So the flu vaccine being a clear example. People aged 65 years and over are eligible, and then there are also separate risk groups eligible groups based on their clinical risk. For the over 65s, we see good uptake generally of about 78% locally. If you look at one of the clinical risk groups, such as pregnant women, where they can have complications if they have flu, uptake there is only 44%. So again, depending on why you're eligible, there can be differences. And it's important to note that many people won't fall into just one of these categories, but we have that intersectionality where you might be in a rural area, suffering from deprivation, and you might be in one of those risk groups rather than based on age, so you might not see the importance yourself directly. So there are lots of different things to tackle to try and improve vaccination uptake rather than just one single fix. And having that high coverage is really important, not only for individual protection, but it also helps protect our wider communities as well. So measles being a really good example of a really effective vaccine, where we have evidence if 95% of a population consistently how vaccinated with both doses, you can stop the spread of measles altogether, even between those people who aren't vaccinated because they can't for clinical reasons. So it's not just about how we increase vaccination in some of these populations for the individuals themselves, but it really does help the whole of Leicestershire as well. And then just to touch on a couple of the things that we're doing to try and increase that, Emma is going to kindly speak to a couple of projects.
Thank you both for that. So the first project I was just going to cover today is the local immunisation street project. We can call it LIST as well. And LIST worked across the system with voluntary care sector organisation, which is Leicestershire Gate. So they support gypsy and traveller communities. And the project actually helped us to understand in public health some of those practical and reality barriers that we weren't aware of before. So actually taking a roving healthcare unit onto the traveller sites locally was something that was only possible through Gate initiating that building of trust and engagement and taking on community ambassadors to advocate for at least discussing vaccinations and feeling safe in their own environment and space. One of the key lessons learnt also that we've taken on board is that we'd love to see an increase in vaccine uptake, or jabs in arms, you could say. But actually, sometimes it's about making sure that people can understand and make their informed decision themselves, which we're all entitled to do. The learning from LIST also has been fed into a second opportunity, which is the Public Health Investment Fund. This is a larger project, which is seeing several voluntary care sector organisations working with ourselves across the system. So ICB, NHSE, and ourselves in local authority. And the opportunity has been brought about by NHS England's funding. And again, we'd love to see that increase in vaccine uptake, but just ensuring that people have better access to vaccines in a safer space, taking into consideration even trauma-informed approaches, is something that's really critical to support our work in this area. Thank you very much.
Thank you. Any questions, Mr. Smith?
Thank you very much, Chair. It's another parent psychology one here. So page 35, the chart on paragraph 45. You've gone to all that hassle, and it's quite a high uptake across the board in Leicestershire of having your child receive the first dose of MMR. And then there's overall there's about a 4% drop on that second one. Why? I don't get it.
I think the first thing to mention is obviously this would be different for every individual. So the answer I'm about to give won't necessarily be applicable to all families. One thing that we do see though, and there has been evidence for, is that some of the low uptake that we see, the answer that's typically given, perhaps as the easy answer, is vaccine hesitancy or misinformation. But the evidence shows that actually that's not the main reason in a lot of cases. There will be some people who, for reasons of their own, will be hesitant about vaccination, but a lot of people trust vaccines and want them. The issue tends to be more around the access to the services themselves and the barriers that they sometimes experience. So for those that are delivered in schools, for example, that's great, but if you happen to be off school that day and then you've got to go to the GP for a follow-up, and then you try getting through with the 8 a.m. rush, and then you have an appointment and that's cancelled, and you then try again another time, and then you get to a point where you perhaps it drops off your list, and it's not for not want of having the vaccine, it's just unfortunately life gets in the way and other things sort of take over. Some of the subsequent vaccines could also almost be a representative of if families continue to have other children, lives get even busier, and it's perhaps easier to have those first vaccines when you are going for your routine appointment with the GP for those checks, as you do in the first few months, after you've stopped having those regular contacts, again, perhaps is less structured and easier to overlook, perhaps, again, amongst everything going on.
If I may, while we're talking about that table, my own area, Market Harbour and Bosworth PCN, is anomalously low, given it's a fairly leafy, wealthy area, given in mind South Blade and Lutterworth to one side of us and Cross Counties the others far higher. And I suggest from the data nerd in me that you might want to find out why that is. James.
Thank you very much. And again, thank you for the report. My question's around it's paragraph 72 on page 41, referring to some communities, including Bangladeshi and Black African populations, show particularly low uptake, in some cases in the low teens or single digits, even amongst those identified as clinically at risk. Do we know why those particular demographics have notably low uptake? Is it a cultural thing about vaccinations? Is it a communications thing? We're just not communicating in the languages that's prevalent in those communities. Is it that we're not putting vaccination places in places where they are? And if the latter, have we reached out to community leaders in both communities to see if there's anything we can do to work with them to encourage uptake of vaccination?
So I think it'll be, again, apologies, it'll probably be a running theme of my answers. It'll be a mixture of factors there, many of which you've mentioned already. There'll be, we'll have overlapping, so some of those communities are perhaps overrepresented in areas of deprivation, for example. So some of that intersectionality that I spoke about is overlaid there. If you've got people who aren't, language barriers may well be an issue, so that's another challenge. You might have some people, if they're new to the country, for example, within that ethnic minority group, just not as familiar with the health service, or if you've come from another country which has a different vaccination schedule, you may not have confidence in the one here because that's not what you've grown up knowing, that this isn't the vaccine that I have, this is the vaccine that I have. So those are factors. Things like getting to the right areas so that you have them in those areas. We've got the roving health unit. I don't know if you're able to touch on that. Do you have information around that one?
So the roving health unit offer is currently provided via patient locally, care locally, PCL. And they will actually go out to various locations. It could be Wickes DIY store in Hinckley, for example, because there may be that area may have been identified as a need, but they can also go out to local community and events. So if there's an African and Caribbean event, for example, more locally, then they'll sometimes attend those events if there's a particular need that's been flagged. So yeah, hopefully that's something that we can look at going forwards as part of that Public Health Investment Fund evaluation as well, just to hopefully answer that further.
And just one other thing that's just come to mind as well, with ethnicity, accurate data recording is always a real challenge as well. So it is low, and I'm not suggesting that it isn't based on these figures, but I know that's an ongoing challenge that the ICB and others work on to improve that recording so that we can correctly infer from the results that we see.
That's the king. Excuse me.
Yeah, Chair.
She's going.
No, it's okay. I was just going to add on to Sean's point regarding our ethnicity within Leicestershire. Sometimes ethnic data is such a low count. So if we come down to individuals, we can't actually see those people on our systems. But from an ethnicity overall point of view, it may be that 2 or 3 individuals making a decision not to attend has quite a stark impact on those percentages, if that helps as well. Thank you. Thank you.
I do. Thank you, Chair. So I was just going to say a few things. So first of all, polio. When I was a kid, polio was a scourge. it was eradicated across the world. It wasn't eradicated without, and that covers every country from rich to poor. So vaccination of all cultures and communities is possible at 100% to get full vaccination strength, the full benefits of vaccination. So what I'm hearing at the moment, I have to be frank, I'm not really, I think there's should we say, a lot of well-intentioned, well-meaning things, but actually what I'm hearing is a lot of soft excuses and explanations as to why people are not getting their children vaccinated for MMR. Now, actually, I have a relative of mine who, unfortunately, before measles was vaccinated against, actually caught measles, and they became deaf, partly deaf because of that, and that's caused them a lifelong problem and all sorts of issues as a result of that. So nobody wants to get measles, nobody wants to get mumps, and you certainly don't want to get rubella. So I do not understand why, if you've got young children and mums and dads, why in some of the PCN areas, and we're not talking just a handful of people, we're talking thousands of people, why we've got some, I mean, the lowest level I think is 87.4%, which is, the medical people will all know, is below the effective rate for effective vaccination, which is 95%. So if I look on the right-hand side of that table, there's hardly any areas within Leicestershire. Actually, the only one that reaches the 95 is Cross Counties, which is South Leicestershire Medical Practice, one of them, which is actually in my area. So I have to say, actually, it gone up from the first phase, which is 95.3. So one would ask the obvious question is, what are they doing that's working that no one else is doing that's not working? Because you've clearly seen slippage, and as the chair mentioned in Market Harbour and Bosworth, and I was very surprised to see that figure, even the original figure, 91.5, that's ridiculously low. So I think we need to do better, quite frankly, and what I'm hearing is a lot of reasons why we're not doing better, but I don't think that washes with me. There's a lot of money spent on this. It is very, very important we get these youngsters vaccinated properly and fully. I had all mine when I was a kid. I didn't know about it, but I had them. Okay, I've got no recollection of it. It didn't do me any harm, and although others may disagree, but the point is I had them. Yeah, and that's it. And I think we just have to get. We can be softly with people, but we can be over softly. And I'm getting the point. We need to be a lot firmer with our population and say, you need to have this. And we need, I mean, you mentioned about kids might miss the school nurse coming in. When I was at school, the school nurse came in. You didn't miss the school nurse. And if you missed the school nurse or doctor that came in, because they did send doctors as well, they got you the next time. Or, you didn't have to wait for an appointment to go to the GP and have to try weaving your way through or go on Rapid Health or some WhatsApp group or whatever it was to get an appointment. You got told, get to this place, you will be there. You got taken, end of. Now, that might not be what people want to hear, but that's the reality. We have to get, I'm afraid, NHS and County Council Health, Public Health has to get a bit firmer with people and say, you need to have this done. Not, there's lots of reasons why you may not want to have it done. And I go back to polio. How do you think your predecessors in health eradicated polio across the world? Africa was certainly not as developed. Most of Asia was not as developed as it is now. A lot of people were a lot less, well off and nourished and all the rest of it. And yet it was done and a very good success story. Now, I'm not saying you're going to eradicate measles, but we do need to do a lot better than this, Chair. I really do think. And, whatever it is, we need to get it done. And we've got a captive audience, youngsters in school. I really can't see what the reason is. I know there's lots of some mums and dads who think, oh, yes, but we need to get over that. You need to work it out how some of these areas are doing better than others and apply that across the board. Sorry, that's not perhaps what you want to hear, but I think we just need to get tough is the answer of what I'm saying. Thank you.
Thank you. And I absolutely agree with the importance of vaccination as a doctor and another doctor. Absolutely agree. And likewise all up to date with my vaccinations. I think some of the work that Emma was talking to will help us understand those reasons so that we can then start addressing those. And we need to do more on it. Absolutely. I think this isn't an excuse in any way. This is something that we see nationally as well. So it's not a Leicestershire specific challenge. This is a national challenge. And I think there is a general wider conversation that needs to be had about benefits and this as well. I don't know if you've got Naomi.
Yeah, thank you. And I agree. I think it's beholden to all of us to promote vaccinations, and I sit in my surgery and can promote that and give people information, but we need to be doing it. We need to be using that make every contact count. So whatever institution, health setting, wherever people turn up, that we are promoting the same message. And I guess part of it as well is if you're out with your constituents, it'd be really helpful to understand if there are things that you're picking up about why people are hesitant to come forward, if there's information that you can feed back into us as the health service and public health, because you're out there talking to people as well. So I think it has to be a joint effort. But I guess what I'm saying is if you have any ideas, suggestions, nuggets that you pick up from your constituents, then please let us know, because it would be really helpful.
So I think, Chair, one of the things is that when I was a lot younger than I am now, one of the things that certainly when I was growing up, and I was certainly aware of, there were children, there were people who were in my age, slightly above, slightly younger, who had caught measles, rubella, mumps, or polio, and you knew about it. You knew what the effects. There was a living memory of if you got polio, you might have to go to the hospital, have an iron lung. I mean, there'll be youngsters today would be thinking, "What the hell is he talking about?" You know, excuse my language, Chair. So I think it's about reminding. We need to remind people about these illnesses, these diseases are very, very dangerous. If you get them, the consequences are severe. They are life-changing. They are life-altering, and it's not us scare 'em, hair 'em. These are, and I think maybe that's what you need to explain to people, because in the stuff I've seen, it says it, but it doesn't explain. You know, I had a family member who was, you know, became deaf in one ear. Okay, that's not the most severe thing that could have happened, but certainly it caused them. They've had a lifelong problem as a result of that. People have much, much worse situations than that. And I think that's the bit I don't think, and maybe you can go too overboard about it, but I think you've got to we certainly don't want to go back to the 1980s with the HIV AIDS pamphlet and all of that. But we need a more direct communication, I think, about what the severity of the illness, if you get it, particularly your young child, if they get it, it's lifelong. Can be life limiting. It can alter their life and the life of their parents forever. So I think it's that and getting that through, because everyone thinks, oh, well, it won't happen to me. It'll happen to them. And then it does happen to them. And you think, oh, right, okay. So I think that's probably where it's not hard hitting enough. The stuff, and I don't have stuff I have seen, it just seems to lack a bit of, punch. If I can put it like that. That's what I wanted to say. Thank you, Chair.
Yeah, I mean, my thought was you'd pay the doctors less and give people an incentive to have it done. But there we go. That was my random way of looking at things. Mr. Whitford.
I like that one. Yeah. I'm on. Okay. Mine is to do with people coming to the country. I am involved in the Filipino community because my wife's Filipino, and I have many, many friends that are Filipino. And their immunisation in their own country is almost non-existent unless you live in the big cities. And I was wondering if there was something nationally we could do, like on applications for visas, to start educating people about when you come here, you should take this up. That's one of them, because there's nothing ever said about that. Do they trust the vaccine? No. Because in their own country, that vaccine might kill them. because most of the vaccines in the Philippines come from China. I'm not going to say too much more about that because that's controversial. I think it speaks for itself. And another one, when they have young children or they have children here, they start looking up the MMR and what comes out on social media, all the old stuff about becoming autistic and all that. So I'm wondering if there's more we could do, maybe through the visa applications, to put something in there and to encourage the people coming into the country to actually take up anything or all of them, especially when they first arrive, so they realise that's something that we do here. Thank you.
Anybody want to come back? It's an interesting idea. I mean, yeah, why not?
No, absolutely. It's not something I'm aware of, so I will take away and have a look, and thank you. And I think the bit you mentioned about the vaccines not trusted, because of when you're Googling and you see that, it's really shocking just how much of a hangover some of those news stories have had and the impact, the long lasting impact they've had. So absolutely, thank you.
Okay, Mrs. Barber.
Thanks, Chair. It's quite interesting. I think from a Healthwatch perspective, we don't have a huge amount of feedback around the vaccinations, although we see the comments that are attributed to people. But just reflecting back to the COVID era, I think we learned a lot in terms of health and social care of people's reasons to for avoidance of vaccines, or mistrust of vaccines, or lack of knowledge of vaccines. And I'm assuming that that kind of history is embedded in the policy and procedures that you're looking to deliver now. For example, going almost street by street, door to door, into companies, all the rest of it. One thing in the paper that does interest me, I think, in terms of Healthwatch, talking about super vaccinator workforces, and later on you talk about gaps in the workforce and the impact that has on the ability to deliver vaccinations. As we talked about, Healthwatch obviously does a lot of work within communities. There are a lot of people very keen living out in our communities to help out in whatever way they can and to support work that benefits other people within the community. And thinking back again to the COVID times, we had a whole workforce made up of volunteer vaccinators that worked under the auspices of St John's. I had the pleasure of doing it. Not sure pleasure is quite the right word, but part of it. And there seems to me to be an untapped element in our communities of people who can help spread the word, and people who could support the vaccinating teams, maybe as volunteers vaccinating, that's up for conversation. But people who live in the communities, understand the communities, and can actually help deliver the messages there. And I don't see that element as part of this policy. I see a lot of work done by NHS staff getting out doing bits and pieces, but I don't see the empowerment of communities to support that work and get in and deliver it alongside the professionals. So I just wonder if that's a consideration to think about.
Thank you so much for that. It is a really important point, actually, and it's something we'll take back to our Integrated Care Board colleagues as well. And form part of that evaluation around the Public Health Investment Fund to show that that element is missing. And like you said, it is an untapped resource. Yeah, thank you.
Okay, thank you, Mr. Piper.
Thank you, Chair. I'm going to sort of cover on some of the things that Mr. King and Mr. Whitford mentioned. Take Mr. Whitford first. I believe that there was a reintroduction of tuberculosis into the country, which came in the country through people from another country. Before COVID, I was aware that there was a tailback of a number of people not having had the MMR vaccine as children. During COVID, they started talking about this vaccination passport and what a terrible thing that was going to be. But I was reading, specifically in America, where there were nightclubs and things like that that were not allowing students in if they hadn't had the vaccine. And it seemed for some reason that I believe in Nottingham University, there was a rash of mumps, which is probably not a pleasant disease for somebody of certainly males of university age. But in other areas, they seem to have a rash of measles or something else. And I don't know why that was regional, but I think that one of the problems that we've had is people coming in from other countries who haven't had the vaccination. I can't remember the name of the gentleman, and I use the term loosely, that scared people off of the MMR, but I believe he's now still making a living giving radio broadcasts, which is not the sort of future I would have recommended for him. But moving forward, I think you're right about the getting the word out, and I think that's a very good idea. Trying to reinforce the safety issue. I mean, we know that dear old, I think his name is Dr. Jenner, whose name I'm sure you all are aware of, proved that the smallpox vaccine, or the cowpox vaccine, was so successful and safe. And I think that not only talking about the need for vaccinations, but also reinforcing the message that some of these vaccinations have been around for years, decades, and I don't quite know how long, and they've been safe. As Mr. King said, yeah, I too went through this process at school of knocking the microphone with my hand, and I thought nothing else of it. When I left school, I went to work for internationally, and it was de rigueur. You just had the vaccinations. There was no question. It was either you had the vaccinations or you were out of work. The point I'm trying to get to, and I'm sure you're pleased when I get there, is that I wonder if our lead, Councillor Harrison there, might go back and talk to the publicity department about making it a council project to promote this, and maybe putting it out not only on social media, not everybody uses that, but also in the county news magazine.
Thank you, Mr. Piper. Yes, all of these things need looking at, and thank you for that. Taking in a roundabout way, taking Mr. King's point, I too am old enough to remember what it was like being at school, and I can't remember not being asked if I want for permission. So I'm going to sound a bit daft here, but can't we just assume that you are opted in until you have to physically opt out? Is that a bit radical? I mean, that's how I remember it. You had to actually go to some trouble to fill out a form. I actually go to the school or say, I do not want my child to do this. I do not want my child to go onto an excursion. Everybody was assumed in. So I'll have to ask my own colleagues, I'm afraid. What do you think?
I think times have changed. I also remember, I'm old enough to remember going into school and it was just what happened. I think people have more information now, but there is consent, and it transpires all ages, and you can't give a vaccine to a child who is saying no, because it's potentially considered assault in the extreme. So there are certain, I guess, rules that we are bound by, but if you are in a clinic and a child is physically saying no, you can't give them the vaccine. So I think this is more about education And it's about providing those opportunities. So if a child is very upset or anxious about a vaccine, but the parent wants them to have it, how can we facilitate that? So not that we pin them down and give them the vaccine there and then, but that we find an alternative, that we find a way in which that parent can attend with that child and the vaccine is given, the child is happy and understands. The other thing you potentially do is if you push it that far, they'll never go near it again. And then you potentially, that is learned behaviour for that child who then goes on and has a family of their own. So I think times have changed and we need to move with the times. And that's where we need to look at alternatives and how we can support people to have these vaccines. And I think whoever made the point, I think, was it Mr. King, about we don't see the impact of measles now, we don't see the impact of polio because we have been so successful, but it is slipping again and we will potentially start to see those complications again. So it is absolutely about education, but it is also absolutely about consent.
I have to say, it is humanly possible to persuade somebody who is needle phobic to cope with it. And in fact, the person I'm thinking of has since had a kidney transplant, which is a heck of a lot of needles. So, you know, as an adult, it's possible. Sorry.
No, thank you. I was just going to say, I think the Mr. King's point earlier about the dangers of some of the vaccine preventable diseases goes hand in hand with Mr. Piper's, thank you, point about the safety of the vaccines. And it's, you know, unfortunately, there are sometimes side effects, as with any medication or any treatment from vaccines, and unwanted issues, but they have been shown to be hugely safe, hugely effective, and you've got to compare that tiny risk from the vaccine with the known larger risk of disease complications, and bear that in mind. It's not a matter of having a small risk from the vaccine or no risk if I don't have the vaccine. It's that comparison with the dangers from the vaccine preventable illness that you may have been able to avoid. Yeah, thank you.
Mrs. Knight.
Thank you. I've actually had measles and I had it before I had the vaccine, so get in there. Quick question. I'm actually in for my shingles jab on Friday and it comes through on the NHS app. So for those who are missing, can you not ping them to remind them to go for the jabs?
Yeah, we do, and we message and we ring and we text. So we do genuinely try every opportunity to follow up patients, bearing in mind that maybe depending on the age range, the medium that you choose to communicate through. But certainly as working in a surgery, my practice nurse it's the nurses who do the vaccinations, but for children who don't attend, they will always follow that up with a phone call. It's coordinated more centrally, but practices will continually engage with parents, follow them up opportunistically. If they come in for another reason, we have alerts that are on our front screens now that will say this, you know, this child hasn't been vaccinated. So again, it's that making every contact count and finding the ways. But yes, we do try.
And secondly, I'd like to follow up on Charles's thing about visas and checking on the visas. My main worry is people who are coming into the country with no visa, and what checks are we doing on them, e.g. the outbreak down in Kent with the meningitis. I'm not saying it's them, but it just seemed, and we've had no report of where it had come from and why there was such an outbreak down there. But, you know, how are we protecting everybody when we've got a cohort of people coming into the country who we don't know what vaccines they've had, what diseases they're bringing in? So, you know, I don't know whether we can do anything about that, but
certainly when we had the refugee programme, there was a whole health check that happened when people came into this country as refugees and looked at what vaccinations they needed along with additional health checks. So there are certain opportunities there, I guess, but yeah, we can always do more.
Thank you, Mr. Smith.
Thank you, Chair. So I think your point there, Charles, about the visas, really good point. I think it should be obviously looked into. You and I also are not only old enough to have the childhood immunisations, but we also both queued up in that line and literally went down the gauntlet and had one in each arm all the way down. When you're in the military, you don't get a choice. And I think it's still pretty much the same today as well. And you know, obviously we did anthrax as well, which was, yeah, hence possibly. However, you know, what we have got is we've all got collective responsibility to encourage people to have vaccines. But you've got, you know, Leicestershire MPs or former Leicestershire MPs that have been very, very vocal about anti-vax and causing, you know, ruptions nationally about it. And still, even though, you know, they've not been in power for nearly 2 years now, are still going on about it and still scaremongering people. So I think this council and the administration and the department itself needs to make a real positive, you know, promotion of the positive aspects of vaccinations to also dispel some of these lunatics that keep going on about the vaccines and how bad it's going to make you, because, you know, the vaccines save more lives than ever they harm. They really do. Thank you.
I agree. It's a very good point. Mr. Poland.
Thank you. Yeah, it's been a really interesting presentation. I possibly came in an item too early with my school vaccination story, so I'm going to replay it now. It does frustrate. I have sympathy with Mr. Harrison when he says, "Can we not just pin them down?" Because what's the point in me giving consent for my kids when they just say I'm not having it and then they don't have it? So, is there any way, I guess, that we can maybe even invite parents into schools when these are happening, so that parents like me would be able to say to our children, you either have it voluntarily or I will turn up at your school in front of all your friends and watch your... So I just wonder whether that might help, or maybe it's a specific case for us, like my family, I don't know. But that's something that as I said, went on for years. Last year he had it because he knew what would happen if he didn't. And polio would be the least of his problems. So we got there eventually, but I do wonder whether sort of parental involvement at that level, if we can't pin them down, is maybe something to think about offering to parents through the schools. In terms of Mr. Whitford's point, I think that's a smashing idea. I really do. I think that, you know, if we were going to other countries, if I was going to, I don't know, America or somewhere, and they said a requirement of your visa is you've got to have X, Y, and Z vaccinations, I wouldn't be sitting there going, why is the US government infringing on my human rights? I'd go, okay, that's their country, that's their choice. So they've decided for themselves it's a requirement, I either have it or I don't go. So I think, yeah, I mean, I think that I would very much support that, and I'm not sure how we can take it forward as a county council, but if there was a way we could, then great, because as I said, I do think that's something that we should look at. Taking Mrs. Knight's point, yeah, I mean, illegal immigrants almost by definition are going to be a problem because they're illegal, and that's one. I mean, that documentation, all sorts of things. So I think that's almost a link, but slightly separate point. If we can get the ones who are coming here legally as a requirement of you know, immigration, I think that would be a good idea.
Thank you, Mr. King.
Yeah, well, Mr. Pollard just said what I was going to say, but I was just going to illuminate that point. But so earlier today, I had to take one of my relatives' pet to the vets because they've got to have pet vaccinations because they're going to the other side of the world in a few weeks' time. And if that pet doesn't have the said vaccinations, it won't be allowed to get on the plane at Heathrow. End of. That just won't happen. So now I'm not saying we do that here. Obviously, well, you know, that's leaving, but people, same thing. To go to other countries, as Mr. Poland's just said, there's quite often a range of criteria, health vaccinations, health situations that you've got to declare. They've got to be validated properly, etc., etc. So I would have, I mean, I've just assumed, perhaps wrongly, that our government was doing the same thing. The Department of Health was insisting that anyone seeking to migrate to the UK legally had to meet certain health criteria. Now, you know, what Mr. Whitford has said, that concerns me, and I would appreciate, I do think, though, Chair, as a county council, that is something we can perhaps, if that is the case, lobby government about, to say you do need to do this, because actually you are creating burden and demand on the health service. If people arrive here and they haven't had their proper vaccinations for all sorts of illnesses and nasties, we're then picking up the tab. But equally, they could also be infective. That's why TB's reoccurred. And going back to what you said earlier, Doctor, going back when I was a lot younger, they used to have sanitariums. We used to have people, they used to be full of people who had got TB, unfortunately, and had to recover. So again, it was in living memory. And it was general knowledge that people knew if you didn't have these things, you could end up like one of those people who went to go to the sanitarium or wherever else it was. Whereas I think we've lost all that. We've lost that knowledge. Younger generations just don't have that knowledge, and they don't understand that actually, if my kids don't have this, or if I don't have this, I'm going to end up potentially in that worst case scenario. And that is a heap lot worse than me having a needle stuck in my arm when I don't want one, or whatever else it is. And, I think it's not just a local, as you say, problem, but I just wonder how we can use ourselves with others to campaign for the government to take a fresh look at it. Thank you.
I just say I must have. It's not. I've made a note to look into that visa element more because it's not an area I'm particularly aware of, and so I don't know if there are differences in requirements with different visas and what the process is. So I wouldn't want to say at this point that it's not something that is considered in the process. It may be. I don't have that experience, and I don't know if it's again differences between visas or if it's a universal thing. So with that one caveat, but otherwise we'll take and have a look further. Thank you.
So we can have reported back on that. Maybe the member might want to write to somebody. I don't know. Mr. Robinson.
Thank you, Chair. My comments really about your you mentioned success rates, failure rates, side effects. Now, one of the reasons I'm here today is because last year when we were elected, my wife and I relaxed our isolation because we were shielding, because we were both over 70. I have a variety of conditions that make me highly vulnerable. I'm also immunosuppressed. And so we shielded for 5 years. We literally stayed in the house, around the garden and what have you. We were very, very careful. We didn't go near anybody, including delivery people. And the reason I'm here, the reason we relaxed our shielding was because we've been following the statistics. And we note now that the COVID statistics are down in the hundreds. So deaths are in the hundreds, new cases are in the hundreds. And I always said once they're down below 1,000, being one of 60, 70 million people, the chances are pretty low of ever catching it. So I'm wondering why we never see more broadcast of figures indicating how successful vaccines are. Some I'm sure are more successful than others. Some are less successful. I've done a lot of research on the COVID vaccines and the COVID disease. And believe me, you wouldn't want to hear what I've got to say about it. I make an academic study of things when I look at stuff. But that's for another day. So I'm just thinking, if you really want to encourage uptake, how about production of some honest statistics showing success rates, failure rates, likelihood of side effects, death rates where that's happened, because there was a lot of discussion about people who died from the COVID jab. Again, I'm not going to talk about that, I'm just quoting it. But to encourage uptake, maybe some useful statistics, medical statistics about each jab would be very useful. And people like myself and my wife who shielded would be able to take appropriate action. Neither of us are actually COVID jabbed. I've had measles, mumps, rubella when I was a kid. I've had tetanus jabs. I've had polio vaccines. By and large, I trusted vaccines for a long, long time until they started playing about with genetics. And again, a whole other subject. But I now feel reasonably safe amongst the population without having to shield, even though I'm on a variety of drugs that compromise my immunity system. some of the comments really, what about some stats that would be useful and might help people to take up?
Yeah, I think it's a really valid point. If we can show the benefits of vaccination and we can encourage just one more person to have it, that's positive, isn't it? And it doesn't take a lot to promote those statistics, you know, to our population and encourage them. And it is all about informed consent, and our job is to give the information. What people choose to do with that is ultimately up to them, and people will make different decisions, but we have to get the information out there. And part of that, I agree with you, is showing success stories around vaccination. So thank you.
Okay, Mr. Mear next.
Thank you, Chair. I've listened to this debate and it's been fascinating, actually. I thought we would be over and done with about 15 minutes because realistically, the uptake of vaccines is quite high. You know, it's just that we've fallen short by a little bit. And I think I see our role as encouraging people to go and get that vaccination and promoting it and being champions of it. I can understand why people have such concerns, but we have to be evidence-led. And we've got a massive immigration population in Leicester City and the surrounding areas, and we haven't had any outbreaks and all the rest of it. So I can understand why some members might be concerned of issues, but we have to be evidence-led. But also we have to be realistic. You know, we want to go on holiday wherever in the world. I don't think we want to be showing all our immunisation records at every immigration point that we want to go in. And I believe there is certain immigration checklists that when you apply for a visa to come into the UK, you have to say that you've had certain immunisations. So I think those things are all in place already. But I think in reality, thank you very much for the report. It is encouraging that so many people are taking up the vaccination. Because if you go onto TikTok now and if you just look at some of the videos of people that are against vaccinations, there's tons, there's actually millions and millions of those videos. So we're fighting against that. So we've got to be the counterweight, and we've got to be encouraging our communities and our population to come out and vaccinate. And I think that's where I see ourselves, not trying to right the wrongs of the world or the visa applications or whatever it might be, people coming in, just for our community to make sure that everybody who's in our community has gone out and vaccinated, and how we can help our health professionals do their jobs. Thank you.
Thank you. Mr. Piper, it's all right.
Thank you very much, Chair. I'm going to come back on one or two different things that different people have said. Mr. Mayor just said about showing your vaccination certificate. When I was working abroad, that's exactly what I did have to do at every place I went to. And I still have my vaccination books at home, as I'm sure many people in the military did. I think Mr. King started talking about Leicestershire. And I thought for a minute he was going to say we would put restrictions on people getting visas into the county, the other thing which you also mentioned was about TB and reminding people about these things and the sanatoriums. And I'm sure that you are probably old enough to remember a black and white film from the 60s called Twice-Stranded Daffodils, which was about a ward in a sanatorium. And it was, if you could walk round the garden and twice-stranded daffodils, you're well enough to go home. Going back to, I think Mr. Poland was talking about with children, a colleague of mine whispered at the time about encouraging your children to take the vaccination or take the mobile phone away from them. Thank you. That did happen, did it? Oh, well, there we go.
There are motivators out there, aren't there? Thank you. Mr. Whitford.
I did say that off the mic. Just coming back to the tuberculosis that I was discussing. There was an outbreak within the Filipino community here in Leicester, but it wasn't brought here by the Filipinos. What it was they was not vaccinated against tuberculosis, and that's why there was the outbreak. And also the only one they test for when you're applying for a visa in the Philippines and most of Asia, I think, is tuberculosis. So That's it. I think we maybe look at tuberculosis again as well, because an outbreak can be so fast and could wipe out so many people. Thank you.
Emma.
Thank you. No, that's a really good point, and thanks for bringing that up. We are looking at TB within Leicestershire and Rutland from a Leicestershire County Council's perspective. We're working on a joint LLR TB strategy, so Leicester, Leicestershire and Rutland's TB strategy. The reason for that is that we have noticed that within our own communities that we are experiencing outbreaks around potentially the Loughborough strain, which started off in Loughborough initially, the area of Charnwood, and your point about not being vaccinated, if you're talking about the BCG, the reason why we don't universally offer that locally is because of the low TB instance within the county, but also it tends to, the predominant reason why you'd vaccinate for BCG now is because you'd want to protect those younger children that could go on to develop TB meningitis. That BCG wanes over time, so the effectiveness of that vaccine will not last through the life course. So that's another reason, just in case people aren't aware. But just to reassure yourselves today that we are looking at TB locally, and also around the visa UK entry applications. There is a UK HSA-led TB screening mechanism in place, but as some of you will be aware, it will look for the active TB cases, not necessarily our latent TB cases, which we are seeing more of within the county for people who have maybe been in the country for 10 to 15 years. So with latent TB, it's lying dormant, it then reactivates as people tend to get older or they might become immunocompromised, and that's why we're starting to see some cases of TB, but it is something that we're looking at in public health.
I've got an interesting story about latent TB in my family that was many, many years, but I won't bore you with that. Mr. Morris.
Yes, you've got to accept there has been some bad effects from COVID vaccinations, and the bad press has really ramped that up, and that is the why we've got hesitancy on other vaccinations. MMR obviously is one we should have, and I'm not so sure about the COVID one though, but I don't know whether you all think it's marvellous, but there's a lot of hesitancy on that now. Thank you.
Certainly right about MMR being ruined by the gentleman who put the stuff out that he did, and it had a massive impact downstream. Yeah, sorry, Mr. Robinson.
Yeah, just to reinforce that point, again, personal experience, my next door neighbour, he had his COVID vaccines. He'd had 3 to 6 months of update jabs, so he was fully vaccinated, and he took a flight to Amsterdam. He was away a couple of days, came back, and the first thing we heard was next door's wife had texted my wife to
should we be raising somebody's personal, sorry to come in, somebody's
well,
personal
no, it's
thing.
just a
I don't think we should be raising if we can identify them. I'm really sorry, you just said that's easily identifiable. I'm not comfortable.
Yeah, okay. Somebody I know then. They took a flight, came back with COVID, and next thing we heard was that they were dead. So COVID doesn't necessarily, the COVID jab doesn't necessarily save you. There are failure rates as well as success rates.
Never meant to totally protect you, but let's not get into that because
no, it's just
it was to make it less bad if you got it.
Well, yes, I appreciate that.
We won't get into that debate now. Right, because this is a wider topic than just COVID, and there's a heck of a lot of things you need to be vaccinated against. So that's just one of the, for most people, less severe things. Anyway, I think we're done. Thank you very much. That was really interesting, and I think virtually everybody spoke on that, which is unusual. So you've triggered a seam of interest in the councillors. So thank you very much. We'll close the meeting now. No other urgent items, and the date of the next meeting is Wednesday, the 9th of September, 2026. So we'll see you then. Thank you very much.